Um, Welcome, everyone. We're here to discuss post-traumatic stress, and everybody here at this panel has experience with it, one way or the other, either personal experience or through their career. So the idea is to simply have a brief run-through discussing sort of the history of post-traumatic stress, otherwise known as post-traumatic stress disorder, what's led throughout history up to sort of modern times regarding that. And then Dr. Mock is going to talk a little bit about current treatments, sort of things that have been offered throughout the years and what some of the modern and future treatments might be. And then we're going to really just open it up and we're going to talk and share our personal experiences with post-traumatic stress. And the idea is that we have this wonderful opportunity to create this post-traumatic resource center aboard the Hornet that then might be modeled to other museum ships around the country, other communities, etc. Because what's being done to help those experiencing and dealing with post-traumatic stress simply is not enough. The statistics bear that out. Just this week, we had, I believe it was 4 Capitol police officers commit suicide since their involvement from the January 6th issue at the Capitol. So whatever is being done in this country to address post-traumatic stress is not enough. And we have this incredible opportunity here on this incredible ship to start something that really will save lives and help people. So this is the beginning of that. And the idea is to, before we can really decide what needs to be done, we need to first understand the problem and the things that work and what we've all seen and experienced that hasn't worked. So that's really the idea of tonight's panel, is just to sort of have a free-flowing exchange of information that will then lead to subsequent discussions in helping us build this center. So I'd like to introduce everyone. I'm Eric Jones. We have Captain Emerson. This is Dr. Caroline Mock, Jackie Kahn, Chris Coco, Marty Parker, Prithvi Nair, Catalina Perez, and Jesse Wims. So these are the panel members for tonight's discussion. Like I said, the purpose of this panel tonight is really just to understand the problems associated with post-traumatic stress disorder, otherwise known as post-traumatic stress, sharing our experiences, brainstorming potential solutions, and planning the next steps. What is post-traumatic stress? Post-traumatic stress basically results from exposure to an overwhelmingly stressful event or series of events, such as war, rape, abuse, or the death of a loved one. It's a normal response by normal people to abnormal situations. And something that's important to remember is it's not what's wrong with you, but rather what's happened to you. Just some quick post-traumatic stress statistics. Of people in the U.S. who experience a traumatic event, 20% will develop post-traumatic stress disorder. And we're going to use the words post-traumatic stress disorder and post-traumatic stress interchangeably. We are liking and wanting to get rid of the D because it's not a disorder. It's something that we're going through and people are going through, and we're trying to change the wordage that will hopefully help reduce the stigma associated with post-traumatic stress. But in a lot of writings and clinical conversations, it's still used as PTSD, so it's going to be used interchangeably. 70% of adults in the United States experience at least one traumatic event in their lifetime. 1 in 13 people in the U.S. will develop PTSD at some point in their life. 8 million adults in the United States have PTSD during a given year. And post-traumatic stress affects twice as many women, 10%, as it does men, which is 4%. An estimated 354 million adult war survivors globally have post-traumatic stress. 30% of Vietnam War veterans, 10% of Gulf War veterans have had post-traumatic stress. And less than 50% of those who have post-traumatic stress reach out for help. 6 of the most common causes of post-traumatic stress: physical abuse, sexual abuse, witnessing a serious accident, witnessing or experiencing mass disaster, war, and emotional abuse. This is a little breakdown. The percentage of people who will likely develop post-traumatic stress after experiencing these traumatic events: 49% of those who have experienced sexual assault, 32% of those who have experienced a severe physical assault, 16.8% who have experienced a serious accident, 15.4% of shooting or stabbing victims, 14.3% of those who have experienced the unexpected death of a loved one, 10.4% of parents of children with life-threatening illnesses, 7.3% of those who have witnessed or been part of violence or war, and 3.8% of those that have experienced a natural disaster. There's some risk factors that can make post-traumatic stress worse: existing mental health conditions, life stressors, genetics, lack of support, neurological, and previous trauma. And these are all things that we hope to address with this resource center in ways that we can help people that experience any of these risk factors. A brief history of post-traumatic stress disorder. Exposure to trauma has been a part of human experience since way back when, since saber-toothed tigers. Back in the early recordings, like the Bible or the epic of Gilgamesh, works by Hippocrates and even Shakespeare, they all mention circumstances which we now recognize and the DSM calls post-traumatic stress disorder. During the Civil War, that was really before the age of modern psychiatry. The general consensus was that only weak-willed soldiers or people with underlying health conditions suffered from post-traumatic stress disorder. It was neither recognized nor treated at the time. However, detailed accounts of flashbacks, panic attacks, depression, insomnia, and suicidal thoughts were all commonly documented. In World War I, modern industrial warfare and modern psychiatry intersected. The number of mass casualties and extensive trauma experienced by millions of soldiers led to an explosion of psychiatric disorders. It was called war neurosis, and attempts by early physicians to diagnose symptoms laid the groundwork for clinical PTSD diagnosis, and it was also known as shell shock. In World War II, there were millions of global casualties that led to advancements in the understanding of post-traumatic stress disorder. In 1943, 43 out of 1,000 people, 1,000 soldiers, were admitted for psychiatric reasons. And after the war, a doctor named Abram Kardner, he published a revised version of his book where he wrote that the stated psychiatric treatment was necessary to prevent chronic cases of post-traumatic stress disorder. 1 in 20 World War II veterans had post-traumatic stress disorder, and it was called combat stress reaction, battle fatigue, or combat exhaustion. After World War II, the causes continued to be studied. In the Vietnam War, the knowledge that was learned from the prior conflicts that was applied during the Vietnam War, there were fewer acute casualties on the battlefields. However, the delayed effects of the combat exposure caused significant impact among the veterans returning home from Vietnam. Nearly 25% of soldiers who were sent to Vietnam from 1964 to 73, which totaled about 700,000 people, later required help for post-traumatic stress disorder. This also led to new diagnostic developments, and it led to the inclusion of post-traumatic stress disorder in the DSM-V3 in 1980. The modern day understanding of it is it's the characterization and diagnostic criteria for post-traumatic stress disorder have been revised somewhat in the subsequent DSM-V versions based on numerous studies over the years. And in the current DSM-5, it's categorized as trauma and stressor-related disorder. So that's basically a quick overview of the history of it. And with that, I'm going to turn this over to Dr. Mock, who's going to briefly talk about some of the treatment options before we open it up.
Hi, I'm Caroline Mock, and I'm a PhD in clinical psychology. And I'm here to talk about the treatment of PTSD. There are numerous treatments for PTSD, and one includes therapy, and sometimes people require medication. So I'm going to talk more about the therapy part of treating PTS. So a very common style of treating PTS is cognitive processing therapy. It's usually about 12 weeks of structured writing and reading that the therapist does with the patient. It's usually about 60 minutes to 90 minutes per session. It's very structured. It often looks at places where a person is stuck in their beliefs or their feelings about the event that happened. So if someone had a trauma that involved a car accident, they may be afraid of loud sounds because of the sound that they heard during the event. And they may be triggered by that. So one of the treatments for that could be exposure therapy. So prolonged exposure, meaning, you expose them to that sound and then show them they're not in danger. And you do that numerous times. They may have a belief that it was their fault, that there was an accident. And so you'd be looking at ways to adjust their thinking to give them a more smooth processing style to know that it wasn't their fault. And they're not feeling so impacted in their self-esteem or their sense of confidence. So another form of therapy is eye movement desensitization and reprocessing, so often called EMDR. And people are specialized in EMDR, are usually master's level clinicians or PhD clinicians. That is a little different from talk therapy that everybody's used to. It requires you going into an office and the professional will have a tool, like it could be a long antenna that they wave in front of you, or it could be their fingers they're waving in front of you, and they're trying to have you feel the experience but not be in danger. And they're also trying to do things neurologically to help reintegrate you. So the medications that are available for PTS include SSRIs, that's working on serotonin receptors in the brain, and SNRIs, which are a newer type of SSRI. It works on the same transmitters, but also norepinephrine. This would be prescribed by a psychiatric nurse or by a psychiatrist. It can treat certain things like anxiety or depression that often comes along with PTS. Medications that were prescribed in the past are benzodiazepines. They don't improve PTSD, and sometimes they can cause harmful side effects. So currently, most people don't go to the doctor and get benzodiazepines. They're addictive, and they have a lot of like grogginess. So they'll start with something a little less depending what your symptoms are. Thank you.
Thank you. So I think now we'd like to really just open this up and have it be an informal conversation. We've all had life experiences. We have a very diverse representation of people that have experience with post-traumatic stress. We have law enforcement represented, we have first responders, we have healthcare workers, we have veterans, and we have family members that have lost loved ones. So I think let's just talk. And the idea is what has worked, what hasn't worked, what have we seen in our lives, and what can we, brainstorming ideas in starting this resource center, ways that we can help people in the community, things that we've seen where people slip through the cracks, with the idea being how do we plug those cracks before they spiral down into alcoholism or drug dependency or suicide. So with that, who would like to talk first?
I'll talk. So I don't suffer from PTS, but throughout my life I've met hundreds of people and very close friends and loved ones that have suffered from PTS, and I didn't even, until recently, I really didn't even know what it was. And I've always just wanted to help and try to, the best way I've always looked at it, especially recently, is I just try to let people open up and just let them know that they're loved and cared about, and that any of these problems that they're having, that it's not their fault, and that even though I don't know what it's like to be them, but I'm just trying to be there for them, and and it seems like that actually helps. But you just have to keep being there, and you have to be consistent with being open, and respectful of their feelings, and not try to push them in any direction. You just try to let them be themselves, and on their own timetable. Just try to give them room to work through their own issues, especially when they're dealing with like one-on-one stuff. You know, I found that it's like letting them be themselves and just be their friends. Sometimes being light about it, sometimes not, and being serious. It seems like it helps me with my relationship with them get closer, and helps them get more in touch with their emotions, and feel more real. I think. I mean, that just the way. I mean, obviously, I'm just looking at it. I'm looking at it from my perspective, but I'm just trying to being there, being open. Don't judge. Don't try to point them in any sort of directions. Just be understanding, be loving, be understanding, and and don't make it too serious, and don't make them feel like they're an outsider or ostracized, or just be there, kind of be quiet inside, and let them feel free and feel strong enough to be themselves, and to quietly suffer, or just maybe share, or whatever. I mean, that's my experience with it.
Thank you.
Yeah.
Yeah, I agree with you. Like, in working with people who have PTS, the people that are closest to them are like their friends and their partners and family, and having a support system that doesn't judge them for their symptoms is very, very important, and it helps in their treatment.
Well, also, many people that I've known throughout my life, and even people I know I've just come to know recently through CVAL and stuff like that. I know some of them. I didn't really realize it was a thing or it was a problem until recently, and I'm still learning how to cope with it, and I'm learning day by day. But it's an important thing, and it's a real thing, and I find that I really care about that and the people that are suffering from it, because it's serious, and it's got to be super lonely to have that, to sit there and suffer like that, and to not me not understanding or being able to put myself in their shoes doesn't mean that I can't just give them warmth and and listen.
So I'll just say, along those lines, it's really easy in our contemporary social media society to overuse terms.
Yeah.
And if we perceive someone who's got PTS, and we say, oh, well, your event is not congruent with somebody who's from a battlefield, it's really not our place to judge. There's a huge spectrum of relativism there. It's relative to how the other things going on with a person in a traumatic event compound the response. So if you get bumped by a car in traffic under the wrong psychological pretenses, you can suffer from PTSD temporarily, or you can have long-term PTSD from the battlefield. This is in by no measure a fixed thing. This is a giant spectrum with tons of variables, and the more we are open to listening to people with it and how they've managed it, because a lot of people are living with it that don't acknowledge the term. They're just going through their everyday.
Well, they might not even know.
They might not know. It expresses itself different ways. I think the youngest, they clinically diagnose PTSD as young as 1 year old. So all that being said, it's very complex. So we need to be equipped here with the right minds and academia and resources if we're going to take this on, because there is a huge risk inherent with playing with people's psyche, and there's inherent dangers there, and as much as we might mean well, we have to be equipped to respond to the huge variances that represent PTS, because it's big and it's way more ubiquitous than we probably like to think.
And I think a big problem also is just the stigma. You can't treat it if they're not coming forward to even say they have any of these symptoms, even if they don't know, like Chris just said, that what they have is PTS, especially in the law enforcement community, and military, I believe, is the same because they're kind of the same. We don't want to show weakness. We don't want to ask for help. That's looked down upon. Nobody in law enforcement community is going to raise their hand and say, yeah, I've got PTSD. So we need to get rid of that stigma. And I'll tell you, probably, 90% of the people in law enforcement have some kind of PTS. If they hadn't suffered traumatic events, they have vicarious trauma. I've had to sit down and talk to kids, an 8-year-old little boy who comes to mind who had tears in his eyes telling me that he doesn't want me to tell his grandmother what happened to him because he's afraid that she's not going to love him anymore. Things like that stick with you. That's vicarious trauma. And so everybody, in law enforcement has that, but isn't going to raise their hand. So what do we do to fight that part so we even get them in the door?
Yeah, I think what you're talking about is the shame of having PTSD, right? I think I heard once someone describe it as having like the scarlet letter on their face. Like nobody can actually see it, but it feels like people can see it, that you're damaged,
Right.
or there's something wrong with you. And that's a symptom of it. And so how do we get people to understand that how they're feeling is actually something that needs to be treated?
I have a question. So recently with the Me Too movement and all the things of that, like that have come about in the past 30 years or whatever. So before that, women were treated poorly. We all know that. And so it was used to be when soldiers would have PTS, and they back in the day they called it shell shock or whatever, but they would was more acceptable than a woman having post-traumatic stress, which happened a hell of a lot more in their lives than in a lot of normal day-to-day life for a man. I mean, is there a way that anybody's looking at that with contemporary psychology and just the way? I'm sorry, I'm kind of a loss for words for this. I don't know if I can articulate it, but since things are becoming more equal, they're still not equal enough. I know, but are people looking at men and women the same pertaining to PTS? Because I know they weren't 20 years ago. It was because women were hysterical and men were shell shocked. Does that make sense?
Yes.
So is that changing at all? Because I feel for the women that are throughout the past and contemporarily that are they getting are people looking at it like it's as real as with a man that was in an artillery barrage nowadays as compared to what they were 20 or 30 years ago? Is that the case, or is it still being forgotten and pushed back? That's just a question.
I mean, I think to your point, and that's one of the things we're working towards is breaking down the idea that it's only
Right.
combat veterans or it's only a certain type of somebody that's gone through something, and realizing and recognizing that post-traumatic stress affects all members of society,
Right.
men and women, children, and making resources available to everybody, regardless of your background.
Right.
So I think that's one of the things that we really need to focus on is getting the idea through that it could be your neighbor, it could be your mother, your daughter, your uncle, etc.
Yeah, so I mean, my question is the barrier being broken now, or is it still a huge barrier? That's the question. I don't know.
I'd say, sorry, I didn't mean to interrupt. I'd say at least on the law enforcement side, I think it's getting a lot better. Most law enforcement realizes the impact of a violent crime against a woman, especially a sex assault, or human trafficking, any of those types of crimes, and they do take it very seriously and work pretty well with NGOs and therapists, anybody who can potentially help a victim of a violent crime, but especially these women who have been kind of forgotten in the past, especially like victims of human trafficking. They've got probably the worst PTSD of anybody in the country.
Right. Well, thank you. That's kind of answers my question a little bit.
I think what I've seen with people who are victims of crime that come into my office who are women is that they often have a bad experience with someone in the system that has told them that they must be making it up. Either a person like that's not trained to work with someone. Someone comes to the police station and they're like, well, that sounds like consensual sex, right? And for the victim, that's re-traumatizing. So I've heard people have mixed experiences with that, but definitely in therapy, they're coming to therapy. I have a women's trauma group, and they are angry. They're angry at men in general. But there are resources there. Sometimes people don't want to seek it out because they don't trust people, but there are resources there.
Well, the studies that I've looked at, women not only are more prone and susceptible to it, but they're flat out. There's more, tracking the symptoms, lack of sleep, anxiety, a lot of the things that we would constitute as a symptom of PTSD. Women's numbers are higher than men's, from what I've looked at. They're not combat related necessarily, or even first responder related. They're societal. So, being mindful of that is huge.
And that might be a good segue to talk about the healthcare workers, and certainly now with the past year and a half with COVID, and I think Jackie has seen that firsthand, but clearly there's a significant number of women in healthcare that are now experiencing post-traumatic stress just from the past 2 years that might not have seen that otherwise. So is that...
Yeah, and I'd like to also touch back on what both Marty and Caroline brought up about shame and stigma in healthcare. I'm a registered nurse and public health nurse, and I have 12 years in nursing, mainly in level 1 trauma centers in the critical care arena. And during my training as a nurse, I've racked my brain on if there was any conversation or study around PTS, and we may have touched on it, but it's not something I recall that we went over. And going onto the unit and getting out there as a nurse, I think what a lot of us experience is, I don't know the proper term for it, but I call it cumulative trauma. So it's actually being witness to trauma on a daily basis, multiple times a day. You're witness to both patients and families that are coming in with traumatic experiences. And, our job and what we signed up for is to stabilize these patients and move them through the system. So in critical care, that's what we do. We stabilize them medically and move them on to the next, and the next patient comes through. And we all love our work, and I think a lot of us who are first responders and in healthcare and law enforcement, and I think we are highly empathetic people who are drawn to this kind of work, and like I said, we sign up for it. But I do feel there's a lack of support around, the cumulative effect that it has on us. There's not a lot of coping mechanism for us. I have seen EAP programs, employee assistance programs, pop up. I'm not sure we're doing justice to those though right now either. I have a colleague who's really struggling after this last year of COVID, and you can tell in her performance and in her personality, and I've just seen her relationships and communication style change. And we recommended her to the EAP, and she was told, well, you have to sign up during 9 to 5, which is her work hours. And she went to the manager and asked for some time off, and it wasn't given to her because we're so short-staffed. We just don't have the people. And so she goes on struggling, and like a lot of nurses I see, you sort of bottle it up and keep on going. because you do want to be there to advocate and support your patients. So I'm really excited about what you're doing here on the Hornet, and to be a part of it, because I know for me, what I've found that doesn't work is bottling it up. That just leads to more isolation. So what I've found that works for me is finding community, and that's the only thing that's ever worked for me in coping, is being around community and connecting with people and realizing that you're not alone, and no matter where you come from or your background, you're going to meet someone who has a similar story or can relate to what you're going through. So it's not easy to sort of get out there when you're going through PTSD, because I think one of the symptoms is isolation and difficulty with relationships. But with community programs like this in place, where there's a supportive, safe environment, I think that's a huge move towards healing large groups of people.
Absolutely, I agree with Jackie. I have suffered from PTSD, not knowing that I had it until recently. I grew up in Bogota, Colombia, where it was this war zone, going through the drug cartels, having bombs explode outside my house, and seeing death everywhere. And it came back now with Black Lives Matter, living in Oakland, having bombs go off, shootings, helicopters. It kind of like brought it back, and I wasn't sure why I was feeling scared, because I'm not scared around dramatic or, dangerous zones, but it brought that back. Also growing up with different instances, among rape and car accidents, in which I almost lost my life. When I was 17, I broke my neck. And recently, at the beginning of the year, I almost died because of an autoimmune disease in the heart. And I felt completely fine, and I still do, but that's because I've had an amazing, huge support system my entire life. And if I hadn't had that, I probably wouldn't be here. I probably would have taken my life. My Sea Valor family has made me very at ease and welcome, and sailing does help, being in the water. Now what the Hornet wants to do, in Junction, I think it's amazing, and I support it 100%. So I'm not a professional by any means, a psychologist, but I do have a heart, and I listen, and like Jesse said, giving people support, it's so important. And letting them just feel free and come forward and, just speak their heart out when they feel comfortable without any pressure. Absolutely.
And I think there is so much shame, I know, in healthcare, and as you said, in law enforcement too. You're looked at to be that hero and that strength, and when you're not feeling it internally, it's very difficult to provide that day after day. And there's not a lot of places for us to go to for help, and I think we need to break down that barrier of shame by developing a language around PTS, and how do we talk about it in the workplace as healthcare providers and first responders.
I forgot to mention that during my 2 hospitalizations in the beginning of the year, every single nurse that was coming into my room, because I was not needing aid right away, their professional help right away, they were checking in on me, I would ask them, how are you doing? And they would pause, and they would be professional, they didn't want to overwhelm me with whatever they were going through, but I had several nurses and even doctors break down in my room. So my room became the resting room, and I loved it, and I still keep in touch with most of those nurses. And I think that everybody in the medical community, as well as law enforcement and every single part, needs so much help right now.
The Sea Valor thing you mentioned, I'm glad you mentioned it.
Absolutely.
Because a huge component of PTS is memory-based, and a lot of the cognitive therapy involves memory and reliving it in order to address it. But I'm a firm believer in overshadowing those memories with new memories, and something that's more powerful on the other end of that negative spectrum. And these days out on the boat, I've seen it firsthand. I've seen the efficacy of maritime, recreational time on the water having profound impact on people. There's a lot of tears on that boat, but we've seen the stories. I mean, anecdotally, I can think of one right now with the shooting in San Jose. The cop got off the boat and sent us a message after and said that he was refreshed, he was relaxed, he was ready to engage in his job more effectively because of a few hours going out under the bridge on a sailboat. I don't know how to explain it. I'm not a PhD, I'm not a doctor, but I have anecdotally witnessed the efficacy of time on the water impacting people and creating new memories that can stomp down the trauma, essentially. It's an antidote.
Yeah, I think I have to agree with that, actually, because, I lost my daughter a year ago. She was my only child. She was 19, and she drowned in Santa Cruz. And, so I haven't been diagnosed with PTSD, so I don't want to take it away from anybody that at this table that has. But, I think what you're saying is it's having to reprogram your neural pathways, because all of a sudden you are left from everything that's abnormal. All of a sudden what you know as being normal has completely been taken away from you. So what you stood for, what you are. I too am a healthcare professional and have been for 20 years. But all of a sudden, in something that you feel so comfortable in, all of a sudden, it's like your own personal earthquake. So you don't know what's normal anymore. So you're stood, and now it's been 1 year post-grief. And I sometimes imagine myself as being reborn. It's almost like being a 1-year-old and figuring out what a 1-year-old has a hard time doing. Well, it's expressing themselves and just trying to fumble and find themselves again. And, I think a lot of it is just reprogramming my neural pathways away from what my life was when she was here. Because, as being a mother, regardless of all my other accomplishments in my life, that was one of my biggest accomplishments. It was the only thing that was my label. It was my everything, and being her daughter, being her mother and having her as my daughter, it truly was, through everything I've accomplished in my life, it was my biggest privilege. And so now I have to kind of turn it around and try and see how I can bring myself out there. And, because there is a little remit where there are bereaved parents that I don't want to put them along the same lines as combat and take away anything from anybody, but, you are left feeling so abnormal because you have to reintegrate yourself into society because nothing feels normal. So, even going to the store, I don't even go to the store. I do everything online, so I kind of don't have to see a mother and child interact because it's so painful. It's so hard to know that, I will never be that role again. I will never be a grandma. I will never be called mom again. All of those things, so you can sit in that circle. You can sit in that circle and just gets, it's so easy to get stuck there. But what I have found that's helped me is, trying to meet people that are willing to talk and just witness my grief, and I think that, and I don't want to make any assumptions here, but I do think it might be the same for mental health, is to remove that stigma where people don't, like cancer, diabetes, you can treat all of those things. And like you said earlier, mental health, just because you can't see it, it doesn't mean that it's not there. And I think the more people that are comfortable talking about it as hey, how's your day going? I think that I'm taking it away from grief now. I'm just trying to even talk about mums, that I've met that have lost their children through taking their life and suicide. And, that all of it is just so tragic. It's such a sudden loss. It's so traumatic. But, when you look at what those children went through, they felt so alone. They felt like they were the only ones going through what they were going through. They felt so much shame. They felt like no one would understand them. Everything was happening so virtually in social media, behind screens. So there was no human interaction. As humans, we rejuvenate ourselves through communication, through touch, through hugs, through all of that. And I think these past 2 years, there's been such an absence of that. my personal opinion is, from that, I think we're going to develop a whole different module of post-traumatic. Just because there are people who even didn't have PTS, but now these past 2 years have been so stuck in isolation, that I think completely separate from my story, I think, we'll be having to deal with something like that. But I think, the more that people talk, the more that people accept and feel like it's not so abnormal, I think those are the steps forward that will help. And I think like resources like what you're doing, Eric, and things like that. I mean, the more people that can hear that word and not think, oh God, everyone's talking about, like, oh, okay, so you can jump on that bandwagon and you don't feel so away from it, so detached. Thank you. I didn't mean to silence the table. No. I'm sorry.
No, I think we're just trying to take in and absorb some of what you said. Thank you for sharing that. So, what can we do to help people? I mean, what can we do with this resource center? Are there things that, in hindsight, people that we've lost that we wish we could have done things differently? Are there lessons that we've learned, whether it's personal stories or through careers? Because we have this blank slate here and this incredible venue and a lot of people that really want to do something good. So the question is, what can we do that's not being done? And clearly, if you look at the statistics, not enough is being done. Mm-hmm. So ideas.
I think she nailed it when she said I think there's a term, neuroplasticity, which is basically the rerouting the neural pathways in your brain and we do it every day. We just don't really acknowledge it. But if we had a nice balanced combination of science and medicine, and then, the hand-holding of a community, and you combine those two things, so the research is there, and also if you're not a lab rat, you're a person.
Yeah, welcome them without labeling them.
Correct. Yeah. Mm-hmm. But at the same time, treating it seriously through the science.
Absolutely.
The term that keeps coming to mind when you say that new experience is like having more positive experiences, a corrective experience.
Mm-hmm. Yeah.
Where like if you were injured by a person, like you were assaulted by a relative, then you may be afraid of people, right? So having more positive experience or corrective experiences like Sea Valor, where everyone's welcoming and acknowledging of your struggles, can be a corrective experience, and it changes your neuro pathways that way.
I would love to see some stronger education in healthcare, in nursing programs, for example, so that PTS is better recognized for people coming that are treating in the hospital setting, and just so nurses have a better understanding of how to deal with it at the bedside or recognize it at the bedside.
I think one of the issues as well, and Marty, you can talk more about this, is certainly in law enforcement, as people we've talked to in the first responder community, there's this fear that if you come forward and say, hey, I'm struggling with something, that it's going to affect your career.
Yeah.
And so that's one of the issues as well. Can you speak to that a little bit?
It's a huge fear, because if you have a mental health situation as law enforcement, they may take your gun away, and then you can't do your job. So what do you do? And of course in law enforcement we have a lot of people who take their own lives. In my office we've had 2 people take their own lives in the last couple of years, and that was probably at least one of the things that they were thinking about is, even if they wanted help, they didn't know where they could go without this affecting their career. So there has to be some other route that they can take where it doesn't go through, their employer, and even just informal things like Preeti was talking about, just the fact that people don't physically even see each other anymore. It's terrible. And if we could just even get people in the same room again, I think, not even talking about PTS, but just getting them in the same room, acting like people again is going to be huge. But then getting them out to have those just positive experiences as well. And so maybe, especially with the law enforcement group, we need to take a little more baby steps like that.
Any other ideas?
Do we have an agenda or an idea already prepared on how the Hornet will jump in as far as like utilizing the Hornet itself?
We do. But what we're doing is we're going to do a two-level approach. One is going to be a resource center. It's going to be on the ship. It's going to be open. It'll give basically, this is what it is. Come, we'll have designated people they can see. I mean, good people in the community come in. I treat this, and if you look up, almost everyone treats it, but actually there's only very few that really know what's going on. So we're doing a two-level. We want to set this resource center up where people can come. We'll have offices here. We'll have every weekend we're open. We're going to have someone here. Somebody wants to come in and talk. But the other underlying is we're going to have things like this almost all the time. It's like almost AA meetings where we're going to come. We have some folks on the ship that will be glad to mentor. Start it out, just like, just mentor. Not even mentor, but just get up, start the conversation. And what we need to do is we need to get people before they go south. They get to the Y, they're either going to go drugs, they're going to go alcohol, or just in such a state of a depressed state that then they're down the road and suicide is close. We want to get those people before. So just like today, this is what I want to do, is we're going to have somebody up there that's done. We've got a lot of NAM guys here, Vietnam guys, that they get up. We're going to invite people here. We're going to give a tour of the ship, relax everyone. We're going to have some goodies, maybe these cupcakes that no one's eaten. But we're going to do this, and then we're going to sit down, and he's going to tell his story. So if you look at our website, go to our PTS, they tell the story. So what we want to do, and these folks have had decent lives. I mean, they went through it. They've had some horrible experiences. We had a Marine corpsman embedded in the Marines. We've had pilots shot down, had to kill people to get away, and every day they see this, but they've managed to do it, and it's like. And so we want to have some people up here. Not only that, first responders. I mean, law enforcement, nursing. I mean, my daughter's a nurse at the Oakland City Schools, and those kids are like they're lost. It's almost going to be lost for 2 years, maybe forever. So, but we want to bring somebody up. They can do it. Somebody can sit down and they can look and they can say, "Wow, they got it worse than I did," and they work through it. And I think that's where we start. I mean, 2 levels. We'll do that. We're going to try through funding. We're going to try to self-insure. So if you don't have to go. We're going to pay for that. We're going to pay if you want to go see a therapist. If you want to go see a therapist, we're going to self-insure. It's a hard road. No one's doing this. There's a lot of eyewash out there. There's a lot of, oh yeah, we care, but really nothing's being done. And that's what Eric and I, the conversation we had on the Sea Valor, Eric and I decided we're going to try this, and hopefully with enough support and some publicity and exposure and just word of mouth that this is a good place to send it. Because I'm pretty sure if I was a police chief and I knew my folks were having this and they had a nice, safe place to go, I think I would advocate for that. Maybe it'd be under the table, but they would do it. And that's how we're going to try. It's going to be slow by slow. No one's doing this that I know of. There's Eric and I met. They're doing it's for veterans. It's a course. They do it, but no one's doing it for even If you're a veteran, guess what? You can go to the VA. But maybe that therapy doesn't work. But you go out in the Sea Valor. You go ride bikes. You go do this. It's different. It works different. It's a compliment to me. And so that's what we're trying to do at the Hornet. We're trying to set it up as kind of a prototype of how it works, and we'll give it to everyone. But we're starting in a lower level, and we're going to start up at the macro level. But I think the most effective right away is going to be having 20, 30, 40, 50 people in here just sitting, and like you said, just sitting and talking and knowing that, you know, hey, we're here, you hear a story and you start thinking about it. So we're actually, we're partnering with, it's called SAFE Project. It was an admiral in the Navy. His son died of opioid. So it's called SAFE Project. We're partnering with them. We're partnering with a number of folks around, so we could get this out. We're just a little organization here. We're setting, even though it's a big ship, we've got a little organization here, and it's a grassroots, and that's how really most good things start, is a grassroots campaign. So that's where we're at now. That's our agenda, and things like this, presentations like this, are just wonderful to get us going. It'll be on it'll be on our website. We're going to try to do live, but we're going to try this, and this is one of the best things we could ever do on the ship. And this aircraft carrier, I mean, it projects its power way beyond its location, and since it's been here, we have been a community asset. Heidi over there runs STEM education, 90,000 people, 90,000 kids from basically underserved communities have come through here. And I've actually witnessed like life-changing events for those kids during our STEM education. So that's what we want to make this, a life-changing event. I think once the ball gets rolling and people see what we can do and how it works, and I agree, this is just the tip of the iceberg, and I think the kids are going to be next, and we can do the same thing, get up, see what we can do, but we're here to help.
That's wonderful, thank you. I'm just thinking about the funding. So the counties, every state has a victims compensation fund. So if a person's been victimized, they submit an application to this board, and they can get funding for therapy. And sometimes it's a lot, like thousands and thousands. They'll give you money to move, see medical expenses, if you had a rape kit. But that resource is so helpful and easy to deal with. So all you need is a police report saying you were involved in this criminal altercation, you were the victim of it. They're extraordinarily easy to work with. So if there was something like that for veterans or first responders, a fund that's specifically for them, where they can go to a private therapist, not the VA, where like all their buddies are there and they may not trust the VA anymore, or they're impacted by work, or even like an employee assistance program. Mm-hmm. Some people don't trust the employee assistance program because they can tell their manager, even though they're not supposed to. Right. So private outside funding. So I'm happy to hear that might be a possibility.
I think that's a good first panel. Is there anything anybody would like to add? Or I think this has been a good first one.
This is very moving, and I'm not going to cry. Just saying, it's just beautiful to know that there's people that are out there willing to help, and I think it comes from, like, I have this idea, and then we keep it quiet, and that's the one thing that I admire about Eric, and I brag about it to all my friends and people that I know. It's like, it has to start, it starts right here in your neighborhood, in your neck of the woods, but if you don't start doing something, there will never be change, because people with the mentality that, oh, well, it's too big, I can't accomplish it, I have this idea, it might work. It always starts right here, in your neighborhood, in your city, in your area. And when you speak up, then you have great minds come together and try to help the community and start something. And then pass the word along again, spread it to all of those people that can help, that are willing to pitch in. So
And I think it's
Very
lovely
exciting.
that it's at a place that it's non-invasive, it's non-clinical, you know, so people are not intimidated.
Yes.
They can come in, they can, like you're saying, just come, like Mark was saying, they can just come in and have a chat. You know, you could have like things like bikes, walks. I mean, it's beautiful out there, just healing in nature. You know, there could be like a creativity place, they could be a writing, a journal place, like all these things that people, again, reprogramming your neural pathway from atypical normality. You know, it's things that, say, a big burly police officer isn't going to want to start writing his feelings in a journal, you know, but if he sees a little 10-year-old or a 5-year-old or someone atypical that you would not normally interact with, you know, our circles are so small in our professional lives, in our normal lives, and it's only through these types of pain and hurt do we branch out. Like when I think of myself, I think I would never have come in contact with any of you guys. I hate to say this, if I hadn't have lost my daughter. I'm not saying that that's a great cutoff, but what I'm saying is through the trauma, through the grief, you interact. It opens up different chains where then you can make a connection with other people. And I think this is a fantastic place to be able to do that, where people have stepped out of their circle. You know, it's not anything that we're within our normal circle and our remit. And, you know, I mean, even I think creativity, I mean, I'm not a clinician, but I think creativity opens some kind of healing and purposeful programming. And I think, you know, I'm sure a lot of ex-veterans wouldn't think about painting a rock or sitting at a table and wanting to write a poem, but, you know, like you could kind of do that kind of thing as well, I think, just from a standpoint. But
Yeah, like art therapy.
yeah, like things that you probably wouldn't like always relate PTS and therapy, because I think that's another thing, you know, that's another barrier where people are so like, oh, it's a clinical diagnosis, so that means it needs clinical intervention, and that's it. But that through C-Vela as well, it's not necessarily always the case, and the more people that can see that there's so many different options out there to help them, because it really is not one size fits all, right? You know, everyone, it's all so different. So something that may work for me isn't going to work for you, but vice versa. And then if you're able to create that variation and variety, I think that opens up the table to a lot.
Absolutely. Anything else, Chris?
I will say that some of the studies that have come out lately, like from the clinician side, from the medical side, is they're learning about psychotropic drug use having this really profound effect, ketamine being one. But like I think we should stray away from that as much as possible, at least at first, until we have the resources here to go down those paths. But I think a more organic, social type of treatment and just a forum for these conversations is where we would really fit in, and then maybe down the road we involve other types of, you know, non-conventional treatments, because it's a non-conventional issue. It's not something you can stamp as the same for every person. I can't think of a more nuanced, varying condition, you know, a mental health disorder than PTS, because I mean it can affect people in this huge spectrum. So,
Absolutely.
yeah, I mean, there's cool studies, but what good is that going to do us now? Not much, but this will have an effect, I think. I hope.
Yeah. Great, thank you. All right, I think that's it.
thank you.
Class dismissed.
Yeah.